Thank you to all our senators for being here. We just finished our organizational meeting. So today is Thursday, January 11th, and you are hearing the Finance Committee, and we're welcoming Ben Steffen and the Healthcare Commission. So thank you for being here to bring us up to date. I know we gave you a lot of work over the interim, and we appreciate the reports and the timeliness. So thank you, and the floor is yours.
Thank you very much, Madam Chair, members of the committee. My name is Ben Steffen. With me today, some of you already know Tracy DeShields. She is our Director of Government Relations and External Affairs. I think I got that right. To my left is Stacy House, who is a key leader in our quality reporting and measurement initiative. To her left is Ken Yates Trotman, an actuary by training, and he directs our cost and quality analyses. Many of the mandates you're going to hear about today were done under his direction. And last to the very left is always trusted and very reliable Dr. David Sharp, who heads up our health information technology and advanced care delivery models. I'm going to talk about 5 things today. There's a lot of slides. We'll try to move efficiently through them. However, if you have questions, feel free to ask as we go through the presentations. There are really 5 subjects, so there are separate issues on each one of them. We'll be talking about nursing home acquisitions, a topic that has garnered significant state attention as well as across the country. We'll also be talking about our work in recommendations regarding oversight of small assisted living centers. We have a work group that completed this work on palliative care. And then lastly, we'll talk about insurance mandates, and there are 5 of them this year that we were asked to take on, kind of a new high water mark after a bit of a hiatus on mandates because of the ACA. And lastly, a topic that was significantly debated last session and adopted, the actions the state is taking to protect reproductive health data. Dr. Sharp has been aggressively engaged in that really since the outset of the legislation. If we can go to the next slide, just to remind everyone, the commission has 5 key roles. The existential role is our authority over health planning and CON. We also measure and report on cost and quality of healthcare in the state. We have been very heavily engaged in health technology innovation. We are, given the nature of our work, very closely engaged with all the stakeholders over which we have authority. And lastly, as I'm speaking here today, oftentimes the legislature asks us to consider various policy options they're considering. If we can go to the first area, which is the nursing home acquisition legislation that was passed last year. That legislation really had 2. It activated certain requirements and it directed the Healthcare Commission to convene a work group over the recess. In terms of what we were told to do, that was enacted and the commission has implemented, we were to provide OHCQ with some findings and recommendations on purchasers of nursing homes, to make that information available, to focus on both the character and fitness of the operator, as well as the quality performance of that operator, regardless of whether they were long-standing operators in the state or were coming in from outside the state to acquire a Maryland facility. Based on the information we gathered, we were to pass that on to the Department of Health, and the health secretary had it within her discretion to make a decision on whether a facility should be licensed or additional conditions be imposed as a condition of licensure. We have gone forward and implemented that. I would say that some concerns that were raised during the bill hearings last year, that licensure is a little late to stop a acquisition. Typically, acquisitions occur, and then the purchaser will then go before OHCQ to seek licensure. So the state in that situation would be in a dilemma. The purchase has gone through. The new owner is in the process of taking over operations. And if a license were to be denied at that point, the residents would be certainly very compromised in terms of what would be the nature of the ownership for that facility. So licensure, I think it was argued, was probably late in the process. We continued to hear that as we move forward with the work group as throughout the summer. If we can move to what we are required to do in the work group. And first off, I want to recognize the chair as well as Delegate Rosenberg and Delegate Kerr, who were on that work group and attended all 6 of the meetings that were held in over the summer and fall of this year. It was impressive that in all of the work groups that legislative leaders were really very diligent in participating in the work groups, not only in this one, but as well on small assisted living and palliative care as well. The focus of the work group was really in 2 areas: defining additional standards or procedures regarding purchase, and defining the status of what the state would do regarding reduction in bedrooms, specifically 3 and 4 bedrooms, which there are still a significant number of those across the state. A number of counties have up to 20% of the nursing home beds are actually in these high volume nursing units across the state. Considerable variability, however, across different jurisdictions in terms of the level of triple and quad bedrooms that exist. We can go to the next slide. The group that we formed was inclusive of really the individuals that play a role in nursing home operations and regulations. And I'm not going to go through that list, but you can see very broadly inclusive. And I want to emphasize too that participation was active. We sought out all opinions. There were representatives from the industry who spoke frankly about some of their concerns. Consumer representatives voiced concerns about residents, and we had very good engagement from the respective agencies in state government that play a role. Just a quick background on the industry. We have about 225 nursing homes operating in the state, about 28,000 beds. Currently, down from the pre-pandemic period. As a rule of thumb, nursing homes like to tell you we'd like to have about 90% occupancy. For a host of reasons today, occupancy levels are down. Our estimate is about 77%. And a couple factors are driving that. Families continue to be reluctant to send loved ones into institutional settings, I think is a factor. In addition, workforce challenges that the industry has emphasized are a continuing challenge, make it difficult sometimes for a facility to staff all of the beds that may actually be in the facility. In terms of ownership, we see a continued consolidation. The single owner operation, single owner facility in which is pretty rare. They still exist in some rural parts of the state, but by and large, chains are the major entity that control this industry, with about 60% owned by chains. A couple percent are still owned by hospitals, but over the last decade, we've seen a migration out of skilled nursing units at hospitals as it's become a less attractive vehicle for hospitals to operate. In terms of the patient population, three key components: Medicare, Medicaid, and private pay. Clearly, an attention is on the Medicare population, as it's very closely tied to the impact on total cost of care. A significant number of Maryland Medicare beneficiaries who are admitted to a nursing home actually end up being readmitted to a hospital after that readmission. It's something that is a major focus of the work that HSCRC is doing, and we are MHCC is working along with them to try to mitigate and better manage those readmissions. In terms of where we've been, just a quick note is that we are in Maryland have seen a raft of acquisitions in the period between 2016 and 2021. Maryland was attractive as a state where both large chains and private equity firms could acquire nursing homes. I pointed to three factors. Medicare Advantage penetration is quite low. Two, Medicaid reimbursement, although operators will tell you is not adequate, is still quite a bit more generous than many states, making it an attractive state to establish a facility or to purchase a facility. And three, we have a significantly higher per capita income than many states across the country, meaning that the private pay population might be more, might represent a greater share of the overall nursing home population. But clearly, as the data suggests, we are seeing over the last 5 years significant changes in ownership. We also, as a result of this rapid pace, begin to report to our commission on changes of ownership at our monthly meeting. It garnered significant interest among all the commissioners, with several commissioners taking this on as a particular area of interest, chiding the staff in some respects to gather more information and asking the staff what more could be done. With that as a background, we begin the first work group meetings in July. And as I mentioned, in total, we had 6. I think the work that Dr. House here on my left and another staff member, Jean Marie Gaval, took charge of. They served as the co-chairs, did an excellent job. We first off provided background, made sure there was a level set in terms of awareness, particularly about the nature of private equity. We sought outside experts in the second meeting. And in the third meeting, we asked Bob Kramer, who may be known to some of you, a former House of Delegate member who served in the previous century, I say that somewhat in jest, in the General Assembly, but has in the intervening years has been become a national expert on nursing home and senior living more broadly. He emphasized in particular that it's not only important to look at what's happening at the moment of purchase, but what is happening in the next several years in terms of acquisitions after they've taken place, and to better manage the new operators' operation and care for patients. In the fourth and fifth meetings, we begin to consider the triple and quad bed issue, discussed options for migrating facilities away from those large capacity beds. We also began to consider what sorts of recommendations should be considered to be put forward to our commission on this important topic. They focused on a number of areas. I'll get to that in a minute, but I think what we were surprised about was the fact that there was more consensus among the work group members on the need to do something than we had expected. And that was across the board, from trade representatives, from consumers, and from the various state agency and organization representatives that participated. So I'll talk about the recommendations in three areas: pre-acquisition, post-acquisition, and also roles of other agencies that they are to play a role. The key points here is we, number one, think we should be continuing to do what we are already doing, which is these reports required in the original statute, providing information regarding the nature and character and fitness of the operators, making sure that that information is submitted to the Office of Healthcare Quality and the Secretary for a determination on what actions they can take through a licensure. The importance of this needs to be shared with consumers as well. And what we would propose to do is continue to update our commission, but make that information also available on the various quality reporting websites pertaining to post-acute care that the commission maintains. The commission also feels it's important that the seller notify all residents and families prior to the acquisition going through. The healthcare state ombudsman was emphatic that information needed to be shared with their agency so that they could make sure that they were effective in doing their job. Post-acquisition, we would monitor progress of each nursing home's purchase for about 3 years, monitoring changes in ownership, changing in the workforce, their reported operating budgets, the revenue that they generated, and any other potential challenges the organization faced or the facility encountered. The follow-up reports that we would generate as a result of these would also be shared with the Office of Healthcare Quality and the Office of the Attorney General for potential actions if these reports so warranted it. As it relates to the commission's charges, we do think there are some statutory changes that would be needed. There was considerable discussion about who should deal with the acquisition prior to it being executed. As I noted, licensure is a little bit late. And what we concluded was that although we are not perfectly situated to do this, in that we oftentimes, as a result of our CON authority, we can make determinations of whether a CON is needed today, that we could take this on and do a much more intense assessment prior to acquisition on the character, fitness, and credibility of the ownership group and their plans for that facility. I would parallel this effort to a work that we do for cardiac services, where we have an ongoing review authority with hospitals that offer cardiac surgery and angioplasty, sometimes called percutaneous coronary interventions, in which we have ongoing review of that process. We recognize that we would have to do this in a prompt and expeditious manner. We currently, related to our CON authority, which is for that authority, we're only making a determination that they're not going to change the nature of services offered at that facility. If our authority was broadened, we would be looking at the fitness, character, on plans of a purchaser. But we recognize that instead of 30 days, we would need some additional time, probably an additional staff or an ability to contract with consultants to do these financial assessments. And we would have the ability to, if you will, stop the trains if we so chose. We would also, as a result of the assessment, take a more aggressive role in reducing 3- and 4-bed rooms, with the idea that this is somewhat a taking of property, but we think that currently the clinical evidence and the preferences of patients would dictate that we migrate away from triple and quad bed rooms, and we would give ourselves the authority to move forward with, we're not setting a time frame on this, but we use the term with to the maximum extent possible when an acquisition occurs to obtain a commitment from that purchaser that they would reduce their triple and quad beds to single and double beds going forward. Recommendations for other agencies within state government are also included in our report. And we do recommend that OHCQ report findings on its surveys more directly to the MHCC and make those more publicly accessible. They are available on the OHCQ website, but we believe there's more that can be done to make deficiencies and findings by the Office of Healthcare Quality more readily available. And in particular, we think in that key window between the time the acquisition occurs and the first few months, that there should be an inspection on the part of OHCQ after the ownership action has occurred. We think there is potentially a role for the Office of the Attorney General. They were interested, but did not volunteer during the work group a particular role that they would have. They would play, but we think it's very important that when needed, the Office of the Attorney General can intervene through litigation and stop an unsavory operator from practices or divest themselves from ownership. And lastly, the Office of Long-Term Care Ombudsman, we see a continuing expanded role for them to play in looking at playing a role and making a recommendation during the acquisition process. I'll stop here before I move on to assisted living for any questions.
Do our senators have any questions? Senator Ellis?
Yeah, thank you, Madam Chair, and thank you, sir, for your presentation. And so following your presentation, I didn't see where you addressed directly a situation where a nonprofit nursing home is sold to a for-profit entity. And I'm always curious what happens to that sale price when monies go from the buyer to the seller, and the seller is a nonprofit. I had a similar situation in my district, and I couldn't get answers out of them. It was followed up. So what's the role in monitoring that situation, please?
So currently, as part of our determination, the seller will identify the price that they are paying for the facility, but we don't have a direct role in determining how any revenue from a sale is actually distributed among the current owners, or what they actually do with that revenue once the ownership transfer occurs. So that's a good point. I mean, I think that what we see generally is that there is a lot of not exclusively for-profit to not-for-profit to for-profit acquisitions. That tends to be the rule, that for-profits are not in the business of acquiring facilities currently. I don't want to say it never occurs, but I think it's much more rare than the fact that for-profit entities, be they private equity or just groups of high wealth individuals coming together to acquire a facility. Those are what we're seeing today. And I think one thing that and Senator Beidel, I think, can confirm this, that Mr. Kramer emphasized it repeatedly, that everything that you're seeing that's going on in the industry, not only in Maryland, but also across the country, be careful to label it not to label it all just simply private equity. There are larger groups of individuals formed that are focusing on the long-term care industry generally. They don't really meet the definitions of private equity.
Thank you. I have a follow-up question, Mayor. And so do you think your agency or state agency, maybe the treasurer's office, should have a role in monitoring the transfer? Sometimes it's a lot of millions of dollars into a nonprofit. Do you think someone in the state should have a role to determine that these monies really don't go into individuals' pockets when it's a nonprofit that owned the facility?
Well, I think that's a good question. I don't feel like I'm equipped to answer that today in terms of what we would do. I mean, let's say it's a example would be Copper Ridge, which was a very respected nursing home and assisted living facility, nationally renowned for its treatment of Alzheimer's. It was purchased by a private equity company from a nonprofit. The nonprofit continues to operate several facilities here in Maryland. And in that case, I'm pretty sure that they felt as though their exposure in the industry was too great. They divested, but they continue to operate. That would be, my assumption was that the revenue was reinvested in the facilities they continued to own. But I think that we can investigate that and get back to the committee.
Yeah. Thank you. I appreciate that. Thank you, Madam Chair.
Any other questions on this issue? Oh, Senator Kramer, sorry.
Thank you, Madam Chair. Ben, good to see you, sir. Quick question, refresh my memory. What state agency is responsible for inspecting nursing homes?
So the Office of Healthcare Quality is required to inspect nursing homes under CMS requirements. It's about 15 months, but because of the pandemic challenges and the workforce issues that OHCQ has repeatedly encountered, I think while they try to make that 15-month deadline, they unfortunately had to let that timeframe slip in a number of cases over the last 4 years as the pandemic really wreaked havoc in the state.
So let me ask you this, and you may have the answer or not. I know that at least in Montgomery County, the state had an MOU with the county, and the county did those inspections. The MOU expired, I believe, October of 2021. The county has reached out repeatedly to try to get it renewed. They don't have the authority right now to do those inspections, and I cannot tell you the length of the list of complaints and the backlog of inspections in Montgomery County because the state's not doing them. And the state has refused, for whatever reason, to renew the MOU to let the county get back into them and make sure that our most vulnerable population is being properly cared for. Can you find out why the state has not renewed this MOU? And, I get it if the state doesn't have the resources, but they weren't using their resources. The county was based on the MOU. And now nobody's doing inspections.
I'll be happy to follow up on that. I was generally aware of that, but I didn't know it had lapsed, and I will follow up on that and get back to them.
And they have been trying very hard to get it renewed, and they can't get a response. Okay, will you make me a promise, Ben? Will you follow up with me, please?
Yes. I promise to follow up with you.
Thank you, sir.
As not only a loyal state employee, but a constituent of Montgomery County, although not of your district. I will follow up.
And that you're forgiven. Thank you, Madam Chair.
Thank you. Senator Washington, you have a question?
Thank you, Madam Chair. Just a quick question. I know this is about nursing home acquisitions and nursing home facilities, and I understand the difference between senior living facilities and these nursing home facilities based on the services offered at those facilities. But I also wondered about the inspections of senior living facilities. Is that done by the state or is that more of the county level?
So that's very interesting. I like the way you use the term senior living because, many of the facilities we're going to talk about today are deliver healthcare within the confines of those, but first and foremost, they're living facilities for seniors. OHCQ also has authority for assisted living. I'm not, and also adult daycare, which is not residential, but does provide ongoing daily care for seniors that prefer that option.
Okay.
So it all falls under the authority of the Office of Healthcare Quality.
But those are only the facilities that offer care. Is that right? Or it doesn't matter which ones? The ones that offer care and ones are just senior living facilities, senior apartments.
So I'd have to get back to you on that. Dr. House, do you know?
They do all assisted living facilities.
But other like senior living, senior residences, I don't want to say until we check
Are
that
you
out.
also including independent living? Because that wouldn't be included.
No, these are facilities that are just senior facility apartments that are just apartment buildings that are sanctioned for seniors, right, over a certain age. And so I wondered, because we have a lot of them and some of them have health issues within the building themselves. And it's also many times that we, I'll ask you off the line because this is about nursing facilities. So I'll follow up with you afterwards. Thank you.
So I'll move to the
Just one minute, please. Senator Lamb has a
sorry.
question. Thank you.
Yeah, thank you. Thank you, Ben. And, I have a large CCRC, continuing care retirement community in my district in Columbia. And a few thoughts. One, you touched on the hedge fund issue. I know that you were looking at healthcare facilities, but a lot of these CCRCs are also being taken, ownership is being taken over by a lot of these hedge funds as well. I wanted to touch on the fact that we do hear from a lot of residents in CCRCs who are on the independent living side that they oftentimes don't have anyone to turn to for concerns or appeals because OHCQ only has authority on the CCRC residents that are in the assisted care facilities, right?
That's correct.
And so is there anything that we can do to help them?
Yeah, the Department of Aging would be the agency that would have the responsibility for the independent living complaints. So I can provide some contacts for you to share with your constituents.
Okay, thank you.
There are no other questions. Mr. Steffens, you want to move on to your small assisted living facility study, 9 beds or fewer?
Thank you. So in the 2022 session of the General Assembly, we were asked to look at small assisted living facilities. And the first question is, what is small in the state? Because if you surveyed different state agencies, there was not consensus on what it's meant to be small. The Maryland Healthcare Commission, who doesn't have direct authority over assisted living, does through its surveys define small as facilities that are 9 or under. We did that not for any really technical or policy reasons. It was because we knew how many small assisted living facilities there were, that in terms of our surveys, we cut it off at 10 or higher, had to complete the survey. 9 or under were exempt. And if you see the slide on the screen today, you see that about 75%. We have about 1,600 assisted living facilities in the state, somewhere just north of 1,200 are 9 beds or fewer. So in terms of volume, the majority of facilities in the state are by our definition small. And the question becomes, I think, and has been asked, should they be subject to the same sort of regulatory regime, the same sort of, and this is a good thing, technical or clinical support that large facilities really don't need. And we were asked through this work group to examine it. If you look at the chart, you'll see that, in larger jurisdictions, the share of assisted living centers that meet the definition of small is, well over 80% in some cases, and it does, I think, indicate that senior living is incredibly important for families in Maryland. And the options that are available need to be varied to reflect the financial resources of families, because generally, with the exception of the home and community-based waiver program run by Medicaid, where state subsidies are available, and a smaller program even still from aging, these facilities are funded through private funds that the resident or the family has to come up with. And I think while we would like to say maybe larger facilities with more amenities would be preferred, if we're asking families to finance that themselves, we have to give them options. And many times the smaller facilities represent a more affordable option than a large, what we would think of as a what's available in a CCRC or what's available in a large Lorien type assisted living facility. Our work group was formed, and it, like the nursing home work group, included representatives from all the relevant state agencies, including OHCQ, Medicaid, the Ombudsman, and as well as the Department of Labor, because we thought there were some workforce issues here. We had consumer representatives, the trade associations were present, and we had large and small operators present as well. This group met again 6 times through the period between the fall of 2022 and the winter of 2023. In fact, our last meeting was just last week. We had experts from state agencies present to us. We conducted a survey of the facilities and found that based on a survey of not only the agencies but other states, found there was no clear definition of what constitutes small. We did note that there's quite a significant gap in terms of quality throughout these programs. They vary significantly across the state, and there's very limited deficiency data that we could put our hands on, and that in fact is one of our recommendations. Is that we would like to get more access to the OHCQ inspection information so that we could better characterize quality, not only to consumers, but by jurisdiction, and to look at variations across the state in terms of not only quality, but access as well. We go to the next slide. We also looked at cost and concluded Maryland tends to be a bit higher cost than some of our neighboring states, and that was reflected in the findings in our surveys with other states. We did find that, as I mentioned, home and community-based waiver program, in which Medicaid pays for nurse or assisted living care for Medicaid eligible residents, was viewed by the operators as not adequate. That's probably not a big surprise, but many of them advocated for benchmarking payment through the home and community-based waiver program as a percentage of what Medicaid would pay on nursing home care. They felt that was a more equitable way to do it and would provide greater transparency and reassurance that reimbursement rates were fair. Now, no assisted living center maintained that payment should be equivalent to nursing home care, but they did have an idea that it should be a fairly significant percentage of what would otherwise be paid by Medicaid for a resident. that is treated instead in an assisted living center. The number that people kind of threw out to me were about 65% of nursing home rates should be afforded to home and community-based programs for assisted living. We need to talk further with our Medicaid colleagues about whether that is feasible. I would note that there's high demand for the home and community-based program. There's a significant backlog and wait list. And although Medicaid has recently expanded it, I think there's significant need in the community to address through a home and community-based waiver program if we're willing to put the effort into expanding it. We had a series of recommendations. I'm going to highlight 4 of these that I think 4 or 5 of these that are pretty important. I think we agreed that there should be a standard definition across all state agencies. Our recommendation was that we define 16 or fewer as small, with a special focus on facilities from 1 to 5 beds, which would be particularly small. We also thought that there needs to be, we are not advocating for CON, but we are saying that there should be more structured assessments of the capabilities and access in different jurisdictions around the state. So that would likely be some sort of a needs assessment done periodically. The MHCC, others, the Ombudsman, Department of Aging could also take this on. And we think that's important as senior living, senior housing is an important challenge, regardless of what healthcare is actually rendered in those facilities for many, many families in Maryland. And we need to pay attention that access, regardless of whether you're in a rural community or in a large urban area, that you have options for loved ones when they have these needs. We emphasized also, I think, the fact that some support from the standpoint of training and education and monitoring is a role that state government should take on for smaller facilities. I don't have a specific cut point here, but in terms of orientation for assisted living facility managers, there are already some requirements, although I think the uptake on some of these has been quite slow. And then we had several suggestions as well that I think we want to make sure we coordinate well with Medicaid on, expanding the home and community-based waiver program. And what we thought was a innovative idea, which was to consider on a pilot basis the eligibility for a family member to be reimbursed for care rendered to a loved one that stayed in the home. Our colleagues at Medicaid have emphasized the opportunities for fraud that would be present in such an arrangement. We're not saying you turn your home into an assisted living center, but oftentimes, and we can attest to that, and many of us have siblings that have taken on the principal role of caring for a parent. If the family is fortunate to be of means and can do that, that's great. But oftentimes, the story is that an individual family member has to choose between a job and caring for a loved one at the home. And we think we can do better, although we recognize this proposal is not without challenges. The entire set of recommendations are listed on the following page. I'm not going to go through all of those. We are presenting the findings from this report to our commission at the January 18th meeting. And as soon as the commission approves the report, it will be submitted to the legislature and the governor. I'll pause here for questions.
Senator Mounts.
Thank you, Madam Chair. Just a quick question. Does hospice care fall under these statistics in the reports, or is that a separate?
That's a separately regulated service. So it's oftentimes both in nursing homes and in assisted living centers. hospice will be brought in the last, the rule is in the last 6 months of life. That's a subjective decision, and Medicare increasingly has shown great flexibility in allowing hospice care to continue, even though the 6-month time period they had initially established has been exceeded. So you would find, if you go into an assisted living center, a number of patients that are being treated not only by the assisted living staff, but a hospice provider who comes in periodically. If death is not imminent, it might be once a week. If death is imminent, they may be coming in daily or even more frequently. In situations where the patient does not have a place to stay, a person may be transferred to an inpatient hospice. But typically, if you're in a nursing home or an assisted living center, you would not be deemed qualified for inpatient hospice care.
Thank you.
So this is the last presentation on, I guess, what we would call post-acute care, but not really. This is a study that was again established under legislation passed in 2022. The role of this work group was to review the role MHCC has. Oops, we're going through, I think we covered that. I think we covered nursing home, move along. And this work group examined the state of palliative care in the state, looked at the capacity of palliative care providers, both statewide and geographically, looked at opportunities for collaborations with hospitals and other healthcare providers, considered ongoing feasibility of how palliative care is paid for, and looked at opportunities for quality monitoring and quality improvement, and then finally considered strategies for making consumers generally more aware of their options for obtaining palliative care services in general. The good news is that we do have palliative care programs either offered by hospitals or in some cases hospices across the state, although it tends to be in rural areas, they are not as plentiful as one might expect. Typically, it's a hospice or the hospital that's offering that service. Several years ago, we did conduct a study based on requirements previously adopted by the legislature that said hospitals, all hospitals with 60 beds or more had to have a palliative care program. So in some of these jurisdictions, it's actually the hospital that's offering the program. In terms of who is patients with what types of conditions are treated under palliative care, it very much parallels hospice. Hospice care is one segment of what's considered palliative care, but it's not the only one. But you can see that patients that seek palliative care based on the data that we were able to obtain heavily weighted in 3 areas: cancer, heart disease, and dementia, with then a variety of other conditions as well being treated. Again, important to emphasize that taking a break from curative care but not really wanting to go into hospice care is one definitional construct of palliative care. And one of the major sort of operational questions starting out was, well, what sort of definition do we want to use for palliative care in the state? We are recommending that the definition established by the Center for Advancing Primary Palliative Care be the one we use. And it broadly states that palliative care is specialized care with individuals suffering from serious illness, but not necessarily at end-of-life situations. The focus is on providing relief from the symptoms of their condition, stress, perhaps even providing some relief for a caregiver within the family that is responsible for this, for the treatment and care of ongoing care of the patient. it focuses on quality of not only for the patient, but also the role that families often play. Under this program, it also it also recognizes the role that there are specialized clinicians that oftentimes are need to be brought in as a patient opts for this regimen, where in a sense they're asking for a relief from curative care, but they're not necessarily giving up. And it's very much individual focused based on where the patient is, the individual's preferences, and the ability of that patient to take a respite from curative care, or perhaps move to hospice care in an appropriate manner. Recognizing again that it's important to keep in mind that palliative care oftentimes does involve specialized providers that are not typically involved in the curative treatment for a patient that need to come in during the period when palliative care is delivered, if it's not end-of-life care. We did a survey and we found that the palliative care programs are, although they're distributed, they are mostly concentrated in urban areas with, as I noted, one option in many of our rural communities, both from the standpoint of the public understanding what palliative care is, as well as caregivers. There is a lack of understanding and appreciation oftentimes for palliative care. Some of our very advanced primary care models, one program that you may have heard of run by Palliative, which is a group operating in Maryland and across the country. They have actually acquired a palliative care program, Iris Care, that they integrate along with their program, which primarily focuses on high-value primary care. They're integrating Iris right into the operations in recognition that your typical primary care physician may not be exactly oriented or trained in this type of care. Likewise, providers have challenges, payers have challenges. Currently, Medicaid and Medicare are the primary funders, but there are recognition within the palliative care provider community that sometimes they're not adequate. Public payers are better than, typically better than the commercial payers, but that's not to say that a palliative care benefit not formally defined is not something commercial payers are ignore. It's just not structured. I want to emphasize there's no insurance mandate on making palliative care available, but clearly the public payers have shown a greater awareness of this type of service. If we go move to the next slide in terms of what we have found. Hospitals are seeing some growth in the use of palliative care programs. Patients over the last several years, while hospice programs have noted that actually their palliative care patients, their volume has decreased rather significantly. We didn't really get a good answer for that. In some regards, it may be balancing out that as options for palliative care are available from hospitals. It may be a patient preference to go through the hospital, oftentimes where they're receiving care, than to go to a hospice, which still has the connotations of end-of-life care. In terms of the other findings we found is that there's, in terms of there's need for greater stability in these programs, that there does seem to be a significant churn in terms of both staff and the commitment of entities that are offering this. Like I noted earlier, the cancer, heart disease, dementia are the primary conditions that are treated through this. And we also, as I mentioned, see palliative care as needing to be a service that's available across the age spectrum, found, as we find with hospice care for pediatric patients, that there is a significant gap in the availability of services. We also found, although technology is slowly taking root in this quadrant of care, it's a bit uneven, and we think there's more to be done with the integration of telehealth for patients that have gone into palliative care, either as an end of life process or as a respite for curative care. We have about 22 recommendations. I'm not going to go through all of these recommendations, but I'm going to sort of focus on the broad categories of these. In terms of public education, we focused on the need for greater public awareness. Provider education, oftentimes clinicians are reluctant to refer for palliative care. I think that increasingly we need to see it as a component of healthcare delivery, and we see opportunities there. As I mentioned, financing is somewhat there, but it's uneven, better in the public payer space than private payer, but more could be done. And we also recognize that community-based palliative care programs, not hospital-based programs, we need to work harder at getting those to take root. Now, when I mentioned hospice, I want to emphasize that all palliative care programs that we surveyed, let me say this another way. All hospices said we provide some palliative care, but when we use the CAPC definition of what palliative care was, about half of the hospices operating in the state admitted they couldn't meet that definition. So when we say we need to do more for community-based palliative care, we need the hospice programs to step up and do more, establish perhaps a different approach to engaging patients so that they're not necessarily seen as only delivering end-of-life care. And then certainly there's, it is a developing area. There's very little data in terms of quality improvement currently. And we think that if we're going to encourage patients, we need to provide evidence that these programs are high quality and meet their needs. There's not many quality metrics currently in place, but several under development. And we would suggest that we track those and implement them when they are ripe for implementation. And lastly, we do think some additional data collection and ongoing basis by the Healthcare Commission is warranted. I'll stop here. There are, as I said, about 22 recommendations. They were supported broadly by the work group. I would note that as a result of this study, we were asked to engage in the Serious Illness Institute, which is an operation run by the National Association for State Health Organizations, largely other states, that we are working with them on refining our approach to serious illness here in Maryland. That's going to go on even though the work group has ended. I'll stop here for questions.
Do any of our senators have a question? Senator Ellis.
Yeah, thank you, Madam Chair, and thank you again, Ben, for your presentation. So looking at your chart on page 24, I'm trying to digest that. It seemed like mainly the rural areas, Southern Maryland, Western Maryland, Eastern Shore, have very small numbers of palliative care being provided. And you mentioned insurances, there's no mandate for them to pay for this, correct?
Correct.
And so would you think that the contributing to the problem is the lower reimbursements that physicians, hospitals receive in any counties that's considered a rural area? Do you think that contributes to that issue, or?
I'm not sure. We didn't hear that. I mean, I recognize that that's a problem we've discussed previously, but in this work group, we didn't hear that that was a driver. I think, in part, you have in those jurisdictions that we're most interested, as are you, there's one hospital, and oftentimes that's the entity that's offering the palliative care. Dr. House, do you know, in sort of the area where I think we're talking about Southern Maryland, do you know who was offering palliative care in those areas? I forgot probably.
The top of my head, but I can get
Yeah.
back to you.
But according to Detroit, it's like just one
Yes.
provider, so.
That's
We
right.
have one hospital, but, you know, we have one organization provide
Yeah.
hospice care too.
And-
And so,
And that's one thing that in terms of providing more competition for hospice care, that is one thing that we've come to the legislature. I know that Senator Middleton was a very committed supporter of hospice care, but we don't have under state law currently, in many of the rural areas, there is no competition. There's one hospice operator and no competition. We've tried a number of different approaches, but haven't really fully solved that challenge. In many of our larger jurisdictions, there's 8 or 10 operators, although I will also say in large jurisdictions, there are usually 2 or 3 key operators. And some are there, but are really not operating.
yeah, I'd love to follow up with you offline to see
Absolutely.
if we can put some solutions in, because even though it's a rural area, we still have the population, we still have the need. So
Absolutely.
thank you. Thank you, Madam Chair.
Thank you. Mr. Sippens, I actually have a question about you. I think you mentioned, if I understood you correctly, you mentioned something about hospice not providing palliative care for these other patients that aren't the end of life.
So, yeah, that was my statement was kind of nuanced, because we did survey all the hospices, but we used the CAPC definition of hospice care, or excuse me, of palliative care, and we found that about half of the hospices did not meet that definition fully. That's not to say they didn't have some elements of palliative care, but they didn't meet all of those. So when we said we wanted the community-based programs to step up, that's kind of what we were suggesting, that to meet the definition of what palliative care services are, they needed to do more than they currently are. Dr. House, do you have any comment on that?
No, that's correct. That's
So it's my understanding, though, that in order for hospice to get reimbursement from insurance companies, it needs to be end of life, like that, the death is within 6 months. So you're shaking your head, Dr. House.
yes, that's correct.
So I don't understand how they could be really doing palliative care in the community, because they're not really doing hospice work at that point,
Do you have
I guess.
So I want to clarify that in terms of the 6-month rule, that really is a Medicare rule that, and I hate to bring personal stuff into this, but my mother has been in hospice care for 6, 10, 12, probably a year and a half. And there's been, she's 98 years old. So, one of the things that's happened with end of life is that when a person has cancer, heart disease, the end is easily predictable. But when you're just old and dying, maybe of dementia, it's very hard to predict end of life. So I know Medicare, certainly has relaxed that requirement, and hospice providers can recertify patients for longer than the quote unquote 6 months. But we'll have to get back to you.
Okay.
I mean, my understanding was that both commercial payers and Medicare did reimburse outside that 6-month window. I know for a fact Medicare does.
Okay. I appreciate that. My dad is almost 96, so I'm where you are, but thank you for your help today.
You have my sympathy. Other questions?
Sure. Thank you, Madam Chair. This committee's been, an advocate for telehealth, and, noticing some of the deficiencies here when it comes to palliative care services. The state, I guess the General Assembly passed legislation to really help expand and advance telehealth, but there were some limits in there when it came to opioids and telehealth that were probably beyond the federal requirements that were even in place. Are there ways that we can look at using telehealth to help make it easier to provide for palliative care?
I'll ask Dr. Sharp. I knew there was a reason why I asked him to come. And when it comes to telehealth, we certainly have one of the leading experts in the state here. So go ahead, David.
Well, thank you. And thank you, Dr. Lamb. That's a great question. So the short answer is yes, there's more we can do. What we found during the pandemic, as you know, there was this huge uptake in telehealth because there weren't many other options for providing care. And while a lot of providers have reverted back somewhat to more inpatient and less telehealth, it doesn't mean that the technology is not available and we can't drive utilization. So the challenge is now, which we're starting to work on with the industry at large, is how do you get people to stay engaged to telehealth? And it's somewhat of a provider challenge because it's not always the easiest modality for providing care, but very effective. And then you have consumers who are somewhat reluctant to want to use technology for care delivery. So it is a fine balance. There's lots of room there, and we are working on that currently, actually, to try to advance telehealth, not only in palliative care, but more in primary care as well.
Okay, thank you.
If there are no other questions, Mr. Steffens, you want to go to your next section?
Yes, and this actually, I want to commend the work that Ken Yates Trotman here on my left has done with 5 insurance mandate studies. We actually have another one that we're working on that will be done in March. It's probably not as timely as I would like, but we simply were inundated with work. And that is the study that looks at the cumulative impact of all mandates, which looks at the insurance cost and says what part of this is really dictated by insurance mandates. I'm not going to talk about that today, but that gives you a good reference point for what the cost is of an insurance benefit that's actually dictated by state law. Not talking about that today, but that will come out in March. We have an authority that the legislature has given us under the insurance article to examine the impact of proposed insurance mandates. Originally, we were told that this was a process that if an insurance mandate was introduced but not passed, and the chair of either Senate Finance or the House Government Health and Government Operations Committee made a request, we would do a study of that insurance mandate on 3 dimensions. The social impacts, which look at the impact on the benefit to the public of making something available, whether the treatments options that are available are of interest to patients, the medical impact, which looks at the effectiveness of those treatments, and lastly, the financial impacts, which largely are the cost impact on the total cost of care, the impact on healthcare premiums, and the impact on particularly small employers, but insurance purchasers in general that might be deterred from buying insurance because additional mandates tend, or at least thought to drive up premiums. So I think we had a very thorough template for doing this. We did a lot of these prior to the adoption, the passage and implementation of the ACA. The ACA did lock down what are called essential health benefits and made it more difficult for states to add insurance mandates, particularly in the individual and small group markets, which are governed more directly and regulated more granularly by the ACA legislation. I think the legislature was very wise in 2014, I believe it was, to pass when the integration of Maryland law and federal law was done. The statute said insurance mandates do not apply to the small group and individual market unless they are specifically included in the statutory language. So that enabled Maryland, if it does adopt insurance mandates, to implement them, but they only are applicable in the large group market, which is the largest insurance segment, but nonetheless does protect us from, if we did impose mandates in the individual and small group market, there would be something that potentially would occur, which is called a defrayal, in which the federal government would say, this is not your definition of an insurance product. And so the state has to pick up the difference between what that insurance would be and the additional cost of the mandate. So I think we were wise to generally exempt those two markets, but allow for the flexibility if the legislature wanted to put them in. Now, I will add that that was viewed as a tremendous threat in 2014. The federal government has never imposed a defrayal on any state, both from the Obama administration, the Trump administration, and the Biden administration, but it still is in law. And it's something to consider as we consider these mandates today. We are looking at 5. One is the annual behavioral health wellness visit requirement that provided for, much like a preventive a primary care visit, required or allowed for a patient to get a behavioral health wellness assessment and it would be considered to be payable from the standpoint of the patient on the same basis as an annual wellness visit, which is with no deductible. The diagnostic and supplemental exams for biopsies is the second that we considered. It actually passed last session, and we're kind of looking back on what we think the impact would be. Keep in mind that I'm sure most of you know that a mammography is treated without a copay, and this bill made these additional diagnostic tests and biopsies would be subject to the same requirements. The third is the treatment for a specific condition of hair loss, alopecia areata, that did not pass, and it certainly garnered some public attention recently, but folks that are suffering from that condition have recently seen some additional clinical options made available to them, and there's been support in the last 2 sessions, at least for the legislature, considering it. The fourth is to consider labor and delivery services. I know that was something that Senator Reddy was particularly interested in without cost sharing, much as some of the preventive and primary care services are governed today. And lastly, we had a mandate that would provide for hearing aids for adults age 18 to 64 as a mandate. Now, many insurance product policies do offer a hearing aid benefit as recognition for the dire implications of hearing loss are better recognized, but it's not mandated under Maryland law. Not going to go into a lot of detail, but I want to, and Ken is available here for questions, point out that in terms of the social, medical, and economic impacts, I thought this summarized the results kind of simply, and also it allows you to gauge the relative impacts on premiums in terms of each of these proposed mandates. Of course, the diagnostic and supplementals are already in Maryland law. And if you sort of look at volumes, annual wellness visits, the labor and delivery services, and hearing aids are going to affect a lot of people. Now, they need to be carefully qualified, particularly when we talk about hearing aids, because I'm sure your loved ones or family members have said, "Can't you hear me?" Well, that's actually a clinical kind of response on the part of many people who have hearing loss. They're very reluctant to to accept hearing aids even when they need them. And the estimate is that uptake is only about 20% of people with hearing losses actually acquire aids. So when we look at up to 500,000 people with potential hearing losses, keep in mind that even if the benefit was available, uptake would be pretty challenging. The PMPM, that's a per member per month cost. You can see these are all modest. The commission always, when it releases these reports in our cover letter, always emphasizes that the cost of individual mandates are rarely even 1%. And as you can see, all of these impacts on premium are pretty low. We did add a cumulative total for if all 5 of these were adopted, it would still have a overall cumulative impact of increasing healthcare premiums by about 0.4% in the commercial market. The alopecia treatment is also applied to Medicaid, and should it pass, that benefit would be required of the Medicaid program to also offer it. But I'll stop here. Before I do, though, I'll ask Ken if he has any comments to make regarding the studies. These studies, by the way, are done by the statute is clear that these have to be actuarially sound. So we contract with actuarial firms. I'm saying this because these are not necessarily cheap to do. And as you think about mandates in the future, be sure to think, are you seriously considering them? Because the cost of a study can range between $25,000 and $50,000 depending on the scope of the study and the various activities the actuarial firm has to undertake. It also means that we will be doing surveys of the insurers, because we want to know, are you offering this benefit even now, even though it's not a mandate? And then we also ask them, what is your experience in your individually the products that you offer on a self-insured basis that are exempt from Maryland law. If they're already offering it in the self-insured market, that tends to give us pretty much credibility that that's a benefit that consumers want and the insurers believe is viable. So turn it over to Ken for any other comments or corrections, as I'm going to sometimes stumble. Go ahead.
No,
Ken.
Ben, you said it well. You know, my only comment here is that these are of course estimates and assumptions. You know, and they are pretty accurate. But just bear that in mind. Also, although these are a lot of mandates, as Ben said, you know, as far as premium are concerned, it's only about 0.4% in increase in premiums in the commercial market.
Yeah, and I regret that we don't have the cumulative impact of mandates on the insurance benefits that's coming out in March. But in general, we say about 30% of the cost of a healthcare policy is tied in directly to services that are required under Maryland law. That's not to say I'm saying they're not valuable. I'm just pointing that out. So the last presentation got on the agenda a little bit late. We're in the process of implementing this law currently. And my voice is starting to fail. So I'm going to turn this over to Dr. Sharp and ask him if he would walk us through that. And I'll add comments as we go along. This has been an arduous effort. And I want to recognize the work of Dr. Sharp, Tracy DeShields, a number of people on David's staff, as well as our colleagues at the department in trying to make this happen. And lastly, we've worked closely with the EHR industry, the electronic health record, and the health information exchange industry, who initially were very concerned that they could do this. We've seen more optimism recently but it will be challenging.
Yeah, and thank you very much. And I would also just like to recognize for the committee the great input and leadership we've had of our executive director, Mr. Steffen, who has been instrumental in helping us to achieve many milestones and goals. So we're very grateful, and he didn't recognize himself, so I thought I would at least acknowledge that great work of his part. So this has been a labor of love, a lot of work. House Bill 812, Senate Bill 786. It's titled Reproductive Health Services, Protected Information Insurance Requirements. What we found working with the technology vendors, lots of stakeholders, it's a clearly divided camp. People who think they can make it work, people who think it won't work. Some like it, some don't. And part of the struggle that we've had over the last many months was to bring people together in the technology community and help them understand how we can make it work. And I'll talk a little bit about that in a few moments. There are several key provisions of this law that I think are notable and we'd like to call out. And I'll just sort of highlight each one of them. I'm sure many of you recall them vehemently. The first one to note is that the law prohibits disclosure of legally protected health information by a health information exchange, and I'll explain that in a few moments, what they are and what they do, or an electronic health network. And here again, I'll talk briefly about them. Any of these entities that are operating in the state beginning as of December 1st, 2023. So just to give you a little backdrop, there are about 16 health information exchange organizations that are registered to provide services in Maryland. And the largest one, which will be familiar to most of you, is the state designated health information exchange, the health data utility, CRIS, the Chesapeake Regional Information System for our patients. They've been before this committee on many occasions in the past. They are the state designated and the largest recognized entity in the state. Others, to give you a few names, SureScripts, they're a health information exchange. We have another state organization in Delaware. Many of these are not in Maryland, but they operate in Maryland. Epic, Cerner, Meditech, these are EHR vendors who also meet the statutory definition of a health information exchange. On the EHN, just a little bit of information about them. They serve as intermediaries between practices, physician practices, ambulatory providers, hospitals, and the insurance carriers. They move the claim transaction electronically. So when you go to your provider and the claim is submitted, these are the entities that actually do the handoff from the provider to the carriers. We have about 29 operating in the state today. And I'll come back to them a little more, but let me finish on the key provisions. The law has fines for noncompliance beginning June 1st of 2024, and they are not to exceed $10,000. And they're based on several characteristics that are defined in the regulation about what qualifies an entity for a fine. The law establishes a protected healthcare commission. In fact, the second meeting of that commission was today, and our executive director is a representative on the commission along with 8 other stakeholders, I believe. And they're just getting started. And what the stakeholders are doing is they're identifying codes and information that pertains to sensitive health information or legally protected health information for recommendations to the Secretary of Health, Dr. Scott, who would then make a determination on whether she accepts the recommendations. And if recommendations are accepted, then it would be up to the industry to implement them. In such case, it would be the Department of Health on the codes, particularly that are selected, and then the Maryland Healthcare Commission on the technology component. So again, this commission is just getting started. I believe their next meeting is somewhere early April, maybe, but they're planning on having a few work group meetings, a smaller subsets of the commission themselves meet between now and then to tackle several issues related to the code selections. So it requires both the Maryland Department of Health as well as the Maryland Healthcare Commission to adopt emergency regulations as a first step. It required the Maryland Department of Health to adopt these regulations within 60 days of the effective date of the law. And the effective date of the law is December 1st of 2023. And it requires MHCC within it's 9 months, so it would be March of 2024 that we had to try to, or 6 months to get them in place. So we have both organizations, being the Department of Health and MHCC. The emergency regulations were submitted to AELR and they're under review. They have not been published yet. The proposed regulations are in line to be published, we believe, in tomorrow's edition of the Maryland Register. We're uncertain, but we'll know within 24 hours. These regulations, both the emergency and proposed, will follow in terms of the emergencies for 6 months. And when it expires, the proposed permanent would be then right on the heels of it. And they match each other, if you will, in terms of what they are. So we've made good progress, and we credit the stakeholders and a lot of good work from the technology vendors to help us get to that point. The law also allows MHCC to develop policies and standards to further bolster the protection and confidentiality of patient information related to this broad category of legally protected health information. And if you're curious to know what areas at first in terms of the code sets that are blocked, if you will, from sharing, they are generally speaking related to mifepristone data, the diagnosis, procedures, medications, and related codes for abortion care and other sensitive health information. There's give or take, I believe the list has about 14 codes, and then there are other codes related to drugs and HCPCS codes, particularly around the medication of mifepristone. It can be expanded upon by this Protected Healthcare Commission, but this is where it's the starting point, if you will. So I will continue on, Madam Chair, a couple more slides, and then I can pause for questions. So let's go on. I think we went too far, Tracy.
I think we can just cover them. I think you did a good job of HIEs and EHNs.
Okay, so I'll take us right to the very last slide and give you a sense of the timeline of what it looks like. What we've been doing, this is kind of a history if you want to get a sense of where we've been and what we started with. We worked with the draft regulations in September. We had public comment in November. They were presented to the commission and they were adopted by the commission and then moved to AELR. I mentioned that the emergency regulations have not been published yet. So we're waiting for an anticipation publication date. The law went into effect in December 1st. Going down a little further, in early December, the commission convened what we call town hall meetings with one with the health information exchange organizations, the second one with the claims clearinghouses to address the technical challenges they might have to implementing the law. So we had overwhelming attendance, lots of good questions, and we follow up with some implementation guidance back to these groups. So in January, one of what we asked for the HIEs and EHNs is to provide us with an affirmation that gives us a sense of where they are and their ability to block the codes and eventually be able to block notes in clinical records. So we're really capturing the full breadth of information related to legally protected health information. We're using that as a stepping off point to in April, going back and asking them to provide us with an update and where they are in terms of meeting the June 1st deadline, which essentially is when conceivably fines could be levied. But the commission has signaled that it intends to work with these technology partners to try to look at waivers and exemptions and granting time. So it isn't viewed as the penalties aren't necessarily viewed as a retaliatory for not meeting goals, but rather as an encouragement that let's keep working towards meeting these benchmarks. And with that, I will pause there. There's much I could go over, but in the interest of time, I should stop. Happy to answer questions, Madam Chair.
Thank you. Thank you for your presentation, Dr. Sharp. And I do have some questions.
Sure.
I was on a call a couple of weeks ago for well over an hour with some hospitals and providers. And they have a great deal of concern about blocking everything for another provider to see, because particularly with out of state, one of the reasons we did this is to protect our out of state patients that might come in for an abortion or for care and then go back to their state. And so if a doctor in their home state doesn't have the information, maybe about some complication that occurred or some other health issue, can't even see the notes that there's going to be issues with how they treat that patient. So that was one concern. The other concern was really some of the technology providers don't feel like they can comply, at least not in time, that they're still working on being able to comply with being able to block all this information. So have you heard those concerns?
Yeah, I'm happy to address it, but I thought I'd see if our executive director would rather take the first.
Well,
shot.
the latter question's the easier one, that there has been a gradual evolution on the technology provider's ability to filter the codes. That initially they were going to block the record. There would be no information for this patient because she had received reproductive health care. That has changed, and many of the technology vendors now, given that we've indicated that first step is to block the codes, and that seems more doable. I don't think Dr. Sharp or I are we are aware these are significant challenges for the vendors. That's why we've signaled to them through the implementation plan, and them moving toward this goal, but not necessarily meeting everything by June 1st would be a way to reassure the technology vendors that we recognize that an implementation in 6 months for technology changes that take anywhere from a year to 18 months, typically in day to day when they make changes, it takes that long to design what has to be done, to put it into development, to test, and then to roll it out to the practices. So I think there's some, not complete confidence that they can do this, but much more relaxed feeling about this, given that we have said at the currently that we recognize no one can implement clinical note filtering, but it's something that they have to do moving forward. Secondly, California enacted a similar law, and the large technology vendors, the Cerners and the Epics of the world, suddenly have the force of California behind them. It's not just Maryland. There are several other states that are looking at this. I think some of that has dissipated. I'll turn it back to David on the provider side questions. He's been very much in touch with those concerns.
Yeah, and it was the premise of of first hearing this, where the providers went, there's no easy way to do this unless we view it as a light switch, all in, off, or on, all out, off. And what we've been able to do is help the providers with the assistance of the technology vendors to understand that they were able to develop software updates to their instances of the EHR solution. The requirement, however, is that the facilities, if you're a hospital, that you actually install that instance, if you will, of that EHR technology. It's the vendors have developed it, and many of them are nearly finished, or many have reported that they've been able to block just the codes. But it's if providers are reluctant to, or their technology systems folks at the organizations are reluctant not to implement that instance, that upgrade, if you will, for lack of better words, then it won't allow for the blocking of those codes. And the only alternative is that you have to block everyone. So as Mr. Stefan mentioned, there's progress made, significant progress. It started out that everyone's, oh my gosh, this won't work. The sky is falling. And now people are moving more and more into making it work. And in fact, I had a call with some folks from New York yesterday who are considering moving in this exact same direction. So Maryland is a trailblazer to some extent, and it creates a lot of this. Whereas if we'd have been third or fourth in line, much of these challenges would have been resolved by now.
Well, thank you for your work. Let's start with Senator, wait a minute, where am I starting? Senator Lamb, thank you.
Sure. Thank you, Madam Chair. Dr. Sharp, I think you bring up an important point that there are other states that are looking at this. And obviously these EMR, EHR exchanges have to figure out how to make this work. And I think, they've been able to figure out a lot of different technical issues, really complex ones. And there's no reason that they can't figure out the technical pieces of this. If there are impediments to that, it's an issue of the willingness to do that. It's not a technical issue of whether or not this could actually be done. And I think that's important to bear in mind as you're working with these vendors and health information exchange systems, that it's really the technical issues can be overcome. And as more and more states figure out how to do this or pushing in this direction, they do need to figure out how to do this. We've been hearing rumblings from the industry that they're obviously pushing back on sharing or pushing to try to shield the sharing of the complete medical record versus just sharing individual components, so like the reproductive health related data. And obviously you have some concerns about this, and the individual patient can always consent to share any information that they want across state lines to other providers and the like. I just want to get a sense of the perspective of the commission that you'll continue to press forward on making sure this is implemented properly to push through the technical issues, because I think the willingness to do this has already been settled by statute, that is the intent of the General Assembly to see this move forward.
And to comment on that, and then I'll yield. Thank you for making that opening remark. I think it's good for folks to hear a physician talk a little bit about that as well. At the same time, I would just say we have partnered with the technology industry, and I was talking to a very large network, electronic health network, this morning, and they left the call feeling very reassured that we are trying to be not the regulator, if you will, but more the educator and more of them to help them figure out how to implement. And so I think we are making huge success in that area, where when this legislation was first passed, it was a challenge we weren't sure we could do. But now I think if you talk to anyone in the industry, they would say the MHCC has really helped us to figure out how to implement these technical requirements.
Okay. I mean, I'm okay with giving them more time and trying to work with them through this, but I think the intent still remains.
Yes, sir.
Yeah.
Good point. Thank you.
Thank you. Thank you, Dr. Lamb. Senator Hershey?
Thank you, Madam Chair. Just a quick statement, Ben. Thank you and your team for your presentation. But just to quickly touch on one of the other very important roles, MHCC, that's leading the CON process for the development and location of healthcare facilities, specifically hospitals. Senator Maltz and I did not want to miss an opportunity while you were here in the Senate Finance Room to advocate for a very specific and important project. We both understand that on next week's agenda, there's a very important issue regarding the hospital in Easton. And while I won't hold you to any promises, we certainly, the entire Eastern Shore certainly hopes that we are going to see a very favorable recommendation.
The recommendation from the staff, we do not take recommendations to the commission unless we are recommending approval.
That's
except in very, very unique situations, and people are advised of those situations so they can opt out of
Right.
public
not looking for any
remediation. And
unique
there's no-
situations then.
There's
just-
no, and I want to say, to say that the challenges of rural health in Maryland this morning, anticipating there might be a question, I did look back. This first came to our attention in 2012, and Shore was told to wait. They were then told, well, you have to downsize. They did downsize. They've closed Dorchester, converted it to a freestanding medical facility. They were told you have to do something about Chestertown. Right. I think things are reasonably smooth. Maybe not exactly what the folks in Kent County exactly want, but there's something. And my apologies, it's taken so long.
Well, I appreciate that and wanted to thank the members that have been on this committee for so long because it was a lot of multiple steps that took us to get to this hub and spoke approach delivering healthcare services in this area. And the spokes have all taken place and we are waiting on the hub. So thank you for all your work in that. Thank you, Madam Chair.
Thank you, Senator Hershey. Are there any other questions? So, Mr. Steffens, I want to thank you and your staff, your team. You did an incredible amount of work this year. I have a lot of reading that I've been doing thanks to you. It's a little stack here, but I really do appreciate the work that you do. And thank you all very much for your presentation today.
And the questions have been noted and we'll be back in touch with you. Importantly, the question on palliative care payments for hospices. I think we have an answer already, but
Okay.
I want to check it.
That's
Thank
great.
you.
Thank you very much. Do I need a motion to adjourn? No? Okay, so the meeting is adjourned. Thank you.